Hi, my name is Megan Cornley,
And I'm Abby McConnell.
and we are both SRNAs from Northern Kentucky University.
Today we're going to be reviewing double lumen endotracheal tubes, including indications, contraindications, risks, and a demonstration of placement. Let's get started.
Let's begin with reviewing why we would need to place a double lumen endotracheal tube. Patient-related indications include attempting to limit infection and/or bleeding to one lung, conditions that require ventilation to each lung be separate, such as a bronchial pleural fistula, tracheobronchial disruption, or cyst. Finally, unilateral lung disease resulting in severe hypoxemia. Surgical-related conditions include lung resections, a VATS procedure, thoracic aneurysm repair, esophageal surgery, and some cardiothoracic surgeries such as a robotic repair of the mitral valve.
Now let's review a few relative contraindications for a left-sided double lumen endotracheal tube. Due to the size of the dual lumen endotracheal tube, placement may be difficult in the following scenarios: limited mouth opening, pre-existing stoma or tracheostomy, difficult airway, and tracheal constriction.
Before we show you how to place a double lumen tube, let's review the complications that are associated with this procedure. Malpositioning of the tube is the most common complication and can result in inadequate ventilation and hypoxemia. Rupture of the thoracic aneurysm can occur with a left-sided double lumen tube if compression of the left main stem bronchus occurs with placement. Damage to airway cartilages and vocal cords. Tracheal bronchial rupture is the most lethal complication, which is caused by overinflation of the bronchial cuff or traumatic placement. Barotrauma, traumatic laryngitis, mucosal ischemia, and inadvertent suturing of the double lumen tube, as evident by the inability to take out the tube during extubation, are all possible complications.
Here's a reference slide for determining the tube size for your patients. The most common size double lumen endotracheal tubes is a 39 for male and a 37 for female.
Now let's review how to set up for a double lumen endotracheal tube placement. First, you'll want to grab your bronchoscope, along with the scope, the screen, and anti-fog. Next, you'll want to grab your video laryngoscope, such as a McGrath or GlideScope, a 10 cc syringe, and a 3 cc syringe. You also want to grab your double lumen endotracheal tube, which comes with the ventilator connections and suction. Lastly, you'll want to make sure you have a clamp and either tape or ties to secure your tube.
Let's review how to use this bronchoscope. A simple downward motion will pull the tip of the scope up, and an upward motion will pull the tip of the scope down. You're able to turn this bronchoscope by simply twisting your wrist.
Now let's review the left double lumen endotracheal tube. As you can see, it says left on the side of it. There are two lumens. The first is a bronchial lumen that holds 3 cc's of air. The next is a tracheal lumen that holds 10 cc's of air. Before we get started, let's review the anatomy. Let's take a look at the adult lung. The adult trachea begins at C6 and ends at the carina, which is around T4 or T5. The double lumen tube is passed through the vocal cords, and at this time the stylet is removed. The tracheal lumen of the double lumen tube sits directly above the carina, and the bronchial lumen is placed in the left mainstem bronchus. To confirm placement, a bronchoscope is utilized to visualize the upper right lobe to ensure the tracheal lumen is truly at the carina. The upper right lobe is often referred to as the Mercedes sign. This sign reflects the apical, posterior, and anterior divisions of the upper right lobe. Occasionally, a patient may exhibit variations in the right upper lobe. These variations can include a quadrification or tracheal bronchus. Take a moment to look at the image on the right. Which image represents correct placement of the left double lumen endotracheal tube? Did you guess correctly? This is the right answer.
I've just pushed rocuronium and it's been 2 minutes. Let's take a look. I'm going to obtain a view with my video laryngoscope. With the cords in view, I'm going to take my left double lumen endotracheal tube with the curvature anterior and place it. Once the bronchial balloon has passed the cords, I'm then going to remove the stylet. Now, with this motion, you're going to corkscrew the tube 90 degrees to the left. This motion is typically met with a lot of resistance. Next, I'm going to inflate my tracheal cuff, attach my connections, and attach my circuit. At this point, we should be confirming the tube placement with end-tidal CO2.
Let's confirm the placement of this endotracheal tube. First, we're going to go down the tracheal lumen. Although you will not see an endotracheal tube in place during this video, this is what you would be looking for through the tracheal lumen. The first task is to find the upper right lobe, also known as the Mercedes sign. Keep in mind a textbook perfect Mercedes sign versus common variations you may find in your patients. Now that we have found the right upper lobe through the tracheal lumen, we're going to remove the bronchoscope and replace it into the bronchial lumen. Our goal while looking down the bronchial lumen is to ensure that the lumen is unobstructed. We also want to make sure that the bronchial carina is distal to the tip of the endotracheal tube. Now that we have verified placement of our dual lumen endotracheal tube using the fiber optic bronchoscope, it's time to isolate the operative lung and ventilate the non-operative lung. If we were wanting to isolate the left lung, then we would want to clamp the bronchial lumen. If we were wanting to isolate the right lung, we'll clamp the tracheal lumen. Because in this patient's case, he's having a left lung procedure, we want to isolate the bronchial lumen, or the left lung. In order to do so, we will clamp the bronchial lumen and open up the bronchial port. At this point, some providers will choose to feed suction down the bronchial lumen in order to ensure that the left lung is fully down. At this point in time, you are able to listen to breath sounds, and the isolated lung should not have any breath sounds, where the ventilated lung will have breath sounds. However, the gold standard of placement is still going to be your fiber optic bronchoscope placement under direct visualization.
It's rare that you would ever have to use a right double lumen endotracheal tube, but just in case, we wanted to make sure you had the indications. Indications include distorted anatomy of the left main bronchus by a bronchial mass, compression of the left main bronchus by descending thoracic aortic aneurysm, a left-sided pneumonectomy, and a left-sided lung transplant. However, typically the left-sided double lumen tube is favored due to the difficult placement of this tube. Let's review how to place a right double lumen endotracheal tube. The tube is first passed through the vocal cords, and at this time the stylet is removed. The tracheal lumen of the tube sits directly above the carina, and the bronchial lumen is placed in the right mainstem bronchus. The Murphy eye of the bronchial lumen is pointed up at the right upper lobe to ventilate this part of the lung. To confirm placement, a bronchoscope is utilized to ensure the Murphy's eye is aligned with the right upper lobe.
Once the lung is isolated, a protective lung ventilation mode is chosen. Tidal volumes for the right lung are typically 8 mL per kg, whereas tidal volumes for the left lung are typically 6 mL per kg. PEEP can be added to avoid atelectasis when maintaining a peak inspiratory pressure below 25 centimeters of water can help avoid barotrauma. You can consider permissive hypercapnia, as this will facilitate the HPV or hypoxic pulmonary vasoconstriction response and reduce cytokine activity. As a reminder, the HPV is an autoregulatory mechanism initiated during one lung ventilation, where blood is shunted from areas of lower ventilation to areas of higher ventilation. This is beneficial as it increases gas exchange and arterial oxygenation. One important consideration is the requirement of a different size tube exchanger if this was to be needed. The specific tube exchanger at Bethesda North is located on the double lumen stock cart in the OR. If the patient is not tolerating one lung ventilation, there are many things to be taken into consideration. Your first consideration should always be malpositioning of the tube, which we discussed being the most common complication of tube placement. This can be verified by visualization with your fiber optic bronchoscope. Remember, it's easy for minimal movement to occur unintentionally. Other measures to take for worsening hypoxia include CPAP, PEEP, and intermittent operative lung ventilation. With all of these measures, stay in communication with the surgeon, although they are likely already aware of your difficulty with ventilation. When using CPAP on the operative lung, as seen in the picture above, start with only 2 centimeters of water and increase pressure as needed. PEEP can be applied to the dependent or non-operative lung to decrease atelectasis, increase lung compliance, and increase FRC. If these measures fail, intermittent operative lung ventilation, coordinated with the surgeon's activities, might be necessary. Thank you so much for taking time out of your busy day to support us with this DNP project. Please continue on to complete the post survey and have a great rest of your day.